coming. So yeah, I think I shared in the email 3 learning objectives today, but actually I'm only going to be able to talk about 2 because the second one is under embargo, and I'll probably talk a little bit about that later. But yeah, I think I'm setting aside most of my time on the first objective, which is using artificial intelligence and machine learning to kind of perfect this idea of a standalone liquid biopsy, which in the third one, I quickly refute its possibility. But anyways, let's start. So currently, obviously, Andrew's going to talk a lot more about this, but the current diagnostic pathway, has really been evolving thanks to the efforts of, these 3 individuals, Lori, Andrew, and Danny. And, the old standard of care was, PSA, combination with DRE, getting a needle biopsy. But what these 3 gentlemen have done is introduce this idea of MRI scans to help determine who should get a needle biopsy. And they've also introduced this idea, or co-introduced with their colleagues, this idea of a targeted fusion biopsy to kind of minimize the adverse events that a gentleman does go through when they do get a needle biopsy. So what is the Pyrrhic victory? So Pyrrhic victory is when you try to achieve something, but at kind of an unexpected great cost. So these are 2 examples that I often think of, where you're trying to achieve a goal or a victory, but you kind of lose something along the way. And it's actually the case for prostate cancer diagnosis. So a lot of these men, because of the nature of the needle biopsy, it's puncturing the rectum in order to get at the needle biopsy with 12 or 13 needles. And it actually happens more often than you think. Urosepsis. And so Rob Nam here, he's shown in a large series that there are men that actually die from urosepsis from the prostate needle biopsy. And obviously, this is changing too. Needle biopsies are going to be happening transperineally as well. But until that happens, this is still going to be the case. And it's a Pyrrhic victory because when you compare it with other commonly diagnosed malignancies, it's really interesting. So, this, in blue are studies done by Drew and Lori, wherein they find that men with low risk prostate cancer, they almost never die from the disease, whereas more men die from the needle biopsy procedure itself. And it's really interesting because when you compare that to the diagnostic pathway for breast cancer, and Eileen, these are your studies, by the way, women with DCIS, they do die, but with women that get a breast biopsy, if you find needle aspirate, they don't succumb to just that. So it's actually the needle biopsy for men, the transrectal needle biopsy for men is the most lethal biopsy procedure in oncology. And it's a concern. So the first learning objective that I want to talk about is this idea that I've been looking at for the last 7 years in combination with a new spin-off at Madison, Wisconsin. The same guys that developed Cologuard for colon cancer, the fecal occult blood test for colon cancer screening. So these guys asked me to join them in this idea of looking at another icky biofluid, semen, for screening for prostate cancer. And so I'm going to talk a little bit about our efforts with artificial intelligence. And so my disclaimer is I don't know a lot about artificial intelligence. I can just say that my experience has been positive. So, with Gregor Diagnostics, this is an idea that you can instead analyze semen. And so what is semen? So it's composed of, the prostate contributes about 20 to 30% of the prostatic fluid. And the rest of it's provided by the seminal fluid, by the seminal vesicles. And so it's within the prostatic fluid, the prostate, through whatever, as the disease grows or evolves, there's exfoliation of either extracellular vesicles or actual tumor cells into the lumen, and this becomes part of the prostatic fluid. And again, upon self-expression and ejaculation, the semen, that's a nice reservoir for these biomarkers. So at Gregor Diagnostics, in combination with Mayo Clinic, we started this first clinical study where we prospectively obtained semen samples from men with no previous history of prostate cancer. And the goal there was to analyze semen to help to develop a screening tool to identify patients with low risk, high risk prostate cancer. And we were going to look at 3 different assays. 2 of them are through ELISAs, and these were patents through the University of Madison, Wisconsin. And the third one was a patent license through a company to Gregor, and that technology is based on looking at these extracellular vesicles that co-express these 3 antigens. And so this was the cohort. After the biopsy report, there's a general mix of men that had varying degrees of risk, of prostate cancer risk, but you can see there's very few high-risk prostate cancer patients, and this is because in the United States and Canada do a really good job of screening for prostate cancer. So mostly low-risk cancer is detected or screened for. But nonetheless, this was the cohort that we started off with. And so with the prostate cancer EVs, what Gregor Diagnostic did was they used this Amnis imaging cytometer. And the really cool thing is, Eileen's bringing one of these instruments to Odette. And so what my previous experience with this imaging thing is, you can use this thing to enumerate, different types of cancer cell garbage in this biofluid. And this is an instrument that's used to also enumerate, lymphoid or leukemic circulating cells, CTCs, breast cancer CTCs and whatnot. So we simply use this machine to enumerate these prostate cancer EVs. So, we analyzed the semen samples from these 167 men, and in collaboration with this Cambridge-based group called BIS Global, we worked with, Sasha here, and he's an artificial intelligence machine learning expert. And he took the data, the imaging data, and he basically tried to figure out, what features out of all the different ELISAs and the imaging cytometer data, which ones were the most important. And so this is his first list. And to my surprise or chagrin, at least 85% of the accuracy of this semen liquid biopsy that we were developing was because of our EV technology. And so, what I learned from this machine learning was that, EVs were the most important feature for diagnostic accuracy. And so, the first thing that came to mind was, can this be reproduced? So I know, Jesse's here, and I need to talk about this, or because he's going to badger me afterwards. So what machine learning technique that we use? I'm really not an expert, but this is what Sasha provided me. And so essentially, they really used this deep neural network regressor method to arrive at this list of features that provided us understanding that EVs, were 85 or 88% responsible for the accuracy rate. But the next slide is the most exciting, which is that, these features allowed us to achieve a really high sensitivity and specificity score. The main caveat here, and obviously, Drew will point this out, is that we're only trying to distinguish cancer from no cancer. And this includes low-risk cancer, which should be ignored. And so, that's the caveat in this study. But, the fact is that our initial experience with applying machine learning techniques was a really positive one, albeit maybe too good to be true. So we thought, okay, the scientific advisory board for Gregor said, can we reproduce this? So we ran another trial, prospective trial. And so this is DADS. So DADS was really just recruiting another set of men. And here's the makeup of the biopsy report. 99 of them had no cancer, 85 of them had low risk cancer, and 33 of them had intermediate high risk cancer. And so again, the same thing, we basically applied the same set of tests. And obviously, we were interested in if the prostate cancer EV technology would, still have the same level of accuracy. So could we reproduce the findings in the previous clinical study? And we did. It was EVs in general were still about 85% responsible for, the diagnostic accuracy. And what's really cool is when you compare the two different features developed in the DADS cohort versus the SFVS cohort. So on the left is the DADS cohort, right? That's 217 men. And on the right is the previous cohort, the SFVS men. Different names, but the same cohort, same test. And just want to point out that, the first two dominant features were the same and in roughly the same proportion. And, I was really relieved when I saw this data, very, very excited. And so, a little bit about DADS, how effective was it? So, DADS was a little bit more intense in that not only were we looking at just cancer and no cancer, which is what this slide describes, but we also wanted to distinguish no cancer from low risk cancer from clinically significant cancer. And so here, just distinguishing no cancer from all cancer, the specificity and sensitivity, okay, that looks a little bit more realistic, great. But when we start stratifying it based on no cancer versus low risk cancer versus intermediate high risk cancer, which is the clinically significant prostate cancer that needs to be operated on, the sensitivity and specificity was really good. I think most importantly, we saw 94-91% sensitivity and specificity when trying to identify intermediate and high risk prostate cancer. So, Gregor Diagnostic is, raised a lot of money to develop this first-in-class semen test for PSA screening. Maybe we'll do a head-to-head versus PSA, maybe not. Maybe we'll do a head-to-head versus prostate health index score, maybe not. Maybe the 4K score, maybe not. But I think, this technology, the exercise of vesicles, has gotten us to this point. And so we're really excited, and maybe we'll be able to open a site here at Sunnybrook where the, men can be enrolled in this trial to see if it can help improve diagnostic accuracy. And maybe in combination with multi-parametric MRI, which is what Drew's going to talk about later. Okay, so I know I said I would talk about this other blood test that looks at another type of extracellular vesicle, or prostate cancer extracellular vesicle. But just recently, and this is really good news, and this announcement will be made later on. But Glyca, which is another company that I'm part of, co-owner of, we've just done a Series A fundraise. But because of that, I've had to put an embargo on this part of the talk. So, but suffice to say, we're also looking at a blood version of a liquid biopsy. The first one was a semen-based one. This one, which is what Glyca is trying to do, look at to clinically validate, is a blood-based one. So I can't talk about that today, but I will talk about something that I'm also very excited about, which is this idea of a new PSA. And so a new PSA isn't new, a new idea. Many groups have tried looking at different glycoforms or complex forms of PSA to improve diagnostic accuracy. And some of those attempts have gotten areas under the curve of maybe 0.8, but usually it's below that. And so this part of the talk, which I'm going to spend about 5 to 7 minutes on, is really looking at a specific glycoform of PSA, which I'm really excited about. I've never seen something perform this well. And this is, wasn't possible without the Assure Biobank, I really got to say, which is a big, a thing that attracted me from Mayo Clinic, where, you have this beautifully curated cohort of individuals providing biofluids for, future analysis of any future biomarker. And, I think this is a beautiful example of us taking advantage of that incredible resource. So going back to the DAD study, we also did PSA analysis. And as you can see here, the sensitivity and specificity just for even any form of prostate cancer is pretty poor. And we already knew this. So could we do better? So there's this idea in the literature that there's special sugar forms of PSA, mostly sialylated PSA, could be cancer specific. And, I just want to give proper recognition of this idea to Rosa Pyrrhic, and she's based in Spain. And what she wasn't the first to discover this, but she was definitely the person that's really promoted this idea, wherein specific glycosylation variants of PSA could be cancer specific. So here is PSA, okay, and at a various amino acid, you have this sialation point here called this alpha 2,6 link, where there's a sialyl group there. What she and others have shown, and this is secreted normally by prostate epithelial cells, but what she discovered, along with some other people, is that there's another type of sugar linkage, and this is chemically known as alpha 2,3 linkage. And so this is the prostate cancer specific PSA. So what she showed that is, if you look at the ratio of this 2,3 variant versus the 2,6, this proportion of the red stuff versus the green stuff, with a certain threshold, which she discovered would be 30%, you could actually distinguish clinically significant prostate cancer from non-clinically significant prostate cancer. The only issue there is that her definition of clinically significant prostate cancer is high risk. But we all know in urology is that what true clinically significant prostate cancer is intermediate form as well. But as you can see here, their form of the assay doesn't provide diagnostic benefit there. And that's because the technology they use is basically an ELISA. And how this ELISA works is at the base, there's a PSA antibody. And so that antibody will collect the PSA. And then to find this 2,3-sialyl glycoform, they use a lectin, which is basically a protein that binds to a specific type of sugar. The only problem there is that this lectin that they use isn't truly specific for this glycoform. And actually, there is no lectin discovered out there that is specific for this lectin. So the problem is that their assay relies on a specific lectin to detect this glycoform. And I guess another caveat of their research is that they were moving the goalposts for what is truly clinically significant prostate cancer. So, we've been collaborating with this chemist at University of Alberta to, instead of using ELISA, using electrospray ionizing mass spectrometry. And so I'm really not an expert in all this, but I'm going to try my best to explain how it works. So what we do is we will isolate, using beads, all the PSA in a serum sample. And then that PSA there's various neuramidases. These are enzymes that remove those sugars off the PSA. And then those sugar variants are then analyzed with this electrospray ionizing mass spec. And then you arrive at this ratio, just like the Rosa Pyrrhic lab did. But, John's basically saying, Hon, try not to explain this technology because it's not going to go well. So hopefully I've explained it to the best of my ability, in that using electrospray ionizing mass spec will offer the most highly quantitative information regarding this ratio of 2,3 versus 2,6 PSA. But what I am good at is explain how well it worked. So here in this chart here, we're just looking at all the different ratios of 2,3 PSA versus 2,6 PSA, sialylated PSA. And these are all the different risk scores. And these are all active surveillance patients through the Assure Biobank. So Gleason group 1 is the low risk, Gleason group 2 is intermediate risk, and Gleason group 3 and Gleason group 4 and 5 are obviously the higher risk prostate cancer patients. And so we find that when we set our threshold at 0.28, we get this kind of area under the curve. We have an area under 0.875 with a specificity and sensitivity of 84%. So meaning that we have a 50% false negative discovery rate in these men, which is not good, but it's still pretty good considering how specific it is for clinically significant prostate cancer. But I think no test is going to be a standalone assay. It's always going to be used in combination with something like an imaging modality like MRI. And so MRI, due to Andrew and Lori's efforts, and Masoom Haider, sorry, it doesn't think I'm here. Okay, so because of their efforts, MRI is now part of the diagnostic pathway, but it's not perfect on its own. So when we use this test test, this 2,3-SIA prostate cancer test, in combination with MRI, we actually do a really good job of identifying men, preventing men from getting a needle biopsy. So, these are all men because of the Assure Biobank, thanks to Stan and, Drew and Lori and Danny. We analyzed about 30 or so men, and using our threshold, we found that, wow, we could spare a lot of men from an unnecessary needle biopsy. Here we avoided them. So that's outcome 1. Outcome 2 is where the test didn't work. So they would, conceivably they would have gotten an MRI, in which they did, but their MRI score would have triaged them or prevented them from getting an unnecessary needle biopsy. So in the end, there's only 2 men out of the 32 where they would have had a false positive result and a false positive result with the MRI. And so, yeah, they were spared, but then these 2 men got a needle biopsy. What's really interesting is that these 2 men actually had kind of low, medium to high volume disease, wherein 4 out of 17 and 4 out of 15 of their needle cores were actually positive for 3+3 disease. And so this is something you actually probably would want to biopsy anyways. But really, with the use of both the imaging and this blood test, we actually reduced unnecessary needle biopsies by 93% in this series of patients. But with the caveat that there's still a false negative rate of 15%, which is still not bad though. So, forthcoming, what we're trying to do is insert into the standard of care made possible by the efforts of, Drew and Lori and Danny and the rest of the community, is the insertion of this PSA test, this new PSA test, prior to an MRI scan to help men decide if they should get a needle biopsy or not. And, this is really the singular goal that my lab's really focused on, is a blood test to help prevent Pyrrhic victories, to minimize Pyrrhic victories, and give men the confidence to know that if they undergo a needle biopsy, it was worth it. So, I just want to acknowledge a lot of different people. Most of all, the Sunnybrook crew, also my lab over the years, the U of A group, Gregor Diagnostics for letting me talk about the semen test that, hopefully will replace PSA as a screening tool, and also my funding sources. And with that, maybe we can enter into a question period, or maybe we should just jump straight into what Andrew was going to talk about.
So what do you think, Eileen? Do you want to do Q&A now, or